Right. So I will rephrase finally the concept of dominance and recessive. In dominance, what we can say that if one allele is defective, right, and when person is heterozygous, abnormal phenotype will be manifested. So we can say that we say a specific gene or specific trait is dominant when person is manifesting abnormal phenotype when he is heterozygous. Is that right? One normal copy, one abnormal copy. But what is recessive trait or recessive gene? Recessive trait is said to be present, or recessive gene behavior is said to be present when in the presence of healthy allele, defective allele cannot make abnormal phenotype. It means when person is heterozygous, disease cannot be manifested as abnormal phenotype. To have disease related with the enzyme, mutation has to be on the both alleles. Because I told you if one is healthy and other is diseased, right, abnormal manifestation will not come, right? But if you have to develop a recessive disorder, then maternal copy and paternal copy both need to be defective, both need to be, yes, abnormal. Only then you will develop abnormal phenotype. So what we learn from it, that in most of the patient who have autosomal dominant diseases, usually they are heterozygous. One copy is defective, other copy is healthy. But in the presence of healthy, abnormal copy is producing the disease, abnormal phenotype. And most of the autosomal recessive disorders, person has both alleles defective. Maternal and paternal both copies should be abnormal. So person should be homozygous for mutant alleles, right? So recessive disease cannot manifest if person is heterozygous, if one allele is healthy. To get a recessive disease, both alleles should be mutant. Sisterly problem is only manifested when both sisters are sick. The brotherly problem is manifested even when one brother is sick, another is okay, but still problem will come. Any question up to this? No. Now, few more questions to you. Up to now we know that when mutations are in structural proteins, these are dominant disorders. When mutations are in enzymes, these are recessive disorders, generally speaking. Some exceptions are there, okay. Now, as a group, let's suppose we are talking about autosomal dominant diseases. Do you think, as a group, autosomal dominant diseases are more severe or autosomal recessive diseases are more severe? Yes. Can you answer me? It's a very simple question. As a group, listen again, I'm putting my question. From New York, we collect all the people with different autosomal dominant diseases and put them on this side. And we collect all other people who are suffering from different type of autosomal recessive diseases, and we put that group there. Now, as a group, autosomal dominant diseases are more dangerous, or as a group, autosomal recessive disorders are more dangerous? She is going to answer us. Yes. As a group.
Normally I would say dominant, but
she is trying to be politician. Normally it happens, but now someone who is less political. I don't want Barack Obama there. Yes.
I'm just as political as she is, but I would say.
I don't want political person. I want who is sure answer. My question is that as a group, dominant disorders are more serious or recessive disorders are more serious? Yes, ma'am. Please look here.
Oh, I'm sorry, I was writing.
No problem. Yes. Autosomal dominant. Oh, he was so much powered with the knowledge, he couldn't stop. He said before someone else can give a wrong answer, he want to give the wrong answer. Who was that man? Yes, my friend, this is wrong answer. As a group, autosomal recessive disorders are more serious, more dangerous as compared to dominant. Look, use the logic. Listen. In autosomal dominant disorder, one copy is healthy and one copy is defective. In autosomal dominant disorder, most of the autosomal dominant diseases are manifested in heterozygous state. So one copy is usually healthy, another is defective. So at least one is functional. But when we are talking about autosomal recessive disease, the disease will only occur when both alleles are defective. So which will be more dangerous situation? When both alleles are suffering. So what we can say today onward, as a group, autosomal recessive disorders are more severe and dangerous because both alleles are defective, and as a group, autosomal disorders are relatively less serious and dangerous because usually they have one copy defective, another is still healthy, even though defective copy produce a product we try to disrupt. What is this? Healthy product. When mutant product interact with the healthy product and disrupt that, we say this is dominant negative behavior. This gene product is behaving in a dominant and negative way. What do you think? If you are strong and you become disturbed and kick the healthy person, and that healthy person cannot work, number one, you are trying to be strong. Secondly, you are trying to be negative. You don't like to, you should not kick, isn't it? So what I'm saying here, number one, this product is not functioning well. Number two, it kick at the ass of healthy product. Is that right? So it is dominant negative behavior. Is that right? But here, sisterly, I don't think sisters do things like that. These are brothers. Right? So here, when sister gets sick, there's loss of function. This is another concept which I want to make it clear. Listen. Usually when genes which are recessive, when they become mutant product usually lose the normal function. Right? As one sister is sick, she becomes simply depressed. She does not do normal function but does not interfere with the healthy sister. Is that right? If one sister is disturbed, she becomes depressed but does not interfere with the healthy person. Is that right? Healthy sister. But this is not good. Here when it becomes sick, not only it is not doing its own function, rather it may disrupt the kick on the other side and don't allow it to work. Rather it has gain of function. What is the gain of function? Kick on the other side. Is that right? So when genes undergo mutation, some genes develop gain of function, some genes develop loss of function. As I told you, one brother get upset and he kick on the other brother. This is mutant brother with gain of function. But one sister become depressed and keep on lying in the bed all the time. What is that? Loss of function. Usually mutations which are gain of function are dominant. And usually mutations which are loss of function are recessive. I'm talking about general principles. When mutations lead to the loss of function, they are recessive. Generally speaking. And generally speaking, when mutation result in gain of function, that is dominant. Am I clear? Okay. No. It depends on, look, sometimes what happens, let's imagine these are two genes for a receptor. Let us suppose this gene is producing a receptor for growth hormone. Okay, no, receptor for any substance. Now this is the ligand which work here and here. Is that right? Now, what happens if this gene become mutant, then this protein also become mutant. Is that right? Now, this mutant receptor behaving in a strange way. You know what it is doing? It start giving the signals even if this is not there. This is gain of function or lose of function? Gain of function. Is that right? So this type of diseases where one copy is defective and that is a gain of function, right? That is usually dominant disorders, right? But another dominant disorder is when one copy get defective and defective product disrupt the normal product. That also result into which kind of diseases? Dominant diseases. Usually when there is an enzyme gene is defective and either enzyme is not produced at all, or enzyme is produced less in amount, or enzyme is produced in normal amount but does not function. All of this is an example of loss of function. Loss of function. Enzyme is not produced, loss of function. Enzyme is produced less in amount, of course, some loss of function. Or enzyme is produced but mutant enzyme does not work, again, loss of function. Usually loss of function mutation result into recessive disorders. Usually. Exceptions are there. Right? Yes, what is your question?
Two questions. Is that the reason why recessive disorders are more lethal?
Yeah. Okay, that's right. He's again dragging me back to the question. He says why autosomal recessive are more lethal or more dangerous and why dominant are less dangerous. Let me tell you. Actually, students have this thing in mind that here if one allele is defective, disease is coming, probably this is more dangerous. It is not so. Why? Because in dominant cases, if most of the dominant patients are heterozygous, right? It means they do have one copy normal and one mutant. Now, naturally, if one copy is normal, even if mutant product interfere with the normal, still some little normal function may be there. Is that right? Clear? Now, we come to recessive situation. In recessive, if one copy is defective, disease is not there. But if we say this specific person is having the recessive disease, it means this person has both genes mutant. And if both genes are mutant, is there any normal product? No. So disease will be mild or serious? Serious. So which diseases should be more serious? Autosomal recessive. Am I clear to you? Right. So as a group, if someone asked you that if you have to, I don't know, this is not a good example, but still if you want to pray in your generations, there should be more dominant diseases or recessive, what should be your choice? Dominant. Recessive diseases are really dangerous. Is that right? This is first thing. Secondly, I'm talking about diseases. Now another thing. As a group, dominant diseases present early in the life or recessive diseases present clinically early in the life. Onset of the disease, when baby is born, it is not necessary that baby is born and immediately clinical manifestation of the inherited disorder come. In some conditions, newborn or when person is born, abnormal clinical manifestations are very soon apparent. In some other diseases, abnormal clinical manifestations may be manifested when person is 15-year-old or 20 years old or 30-year-old, right? So some inherited genetic disorders manifest themselves in childhood, and there are other inherited genetic disorders which usually manifest in adulthood. Now my question is, you are going to be doctor, so I'm trying to give you some basic concept, that as a group, dominant diseases present in childhood or earlier, or as a group, recessive diseases clinically present earlier. Question goes to that lady. Recessive present earlier, why? You don't know. You don't know, but your answer is right. Explanation is very simple. In recessive diseases, both genes are knocked out. Person is born with almost no enzyme. So there is a severe disruption of metabolic pathway. So what will happen? Disease will manifest earlier. Is that right? So, but opposite to that, in dominant disorders, right, because one of the allele is still functioning to some extent, right, other allele is, one allele is mutant, one healthy allele is there, eventually abnormality will manifest, but not necessarily too early in the life. You are getting it? So as a group, autosomal recessive disorder are diagnosed and manifested at early age. And as a group, exceptions are there again, as a group, autosomal dominant disorder manifest in later age as comparison to the onset of age of recessive disorder. So what did we learn up to now? Let me put into perspective. Number one, dominant diseases are usually related with the mutation in structural genes and proteins. Is that right? Mutations resulting in mutant structural proteins. Recessive diseases are due to usually mutation in enzyme system. Is that right? Then, dominant diseases can manifest even if person is heterozygous. Recessive disease only manifests when person is homozygous for the mutant alleles. If he is heterozygous, he will be carrier. He will not manifest the disease. Are you understanding? Dominant diseases are, as a group, less severe as compared to the recessive disorders. Dominant disorder, usually their manifestation and diagnosis is usually late as a group as compared to recessive disorders, where usually manifestations are at early childhood. Any question up to this? There is no question. Okay, let's move forward now. Let's go to that nasty pedigree business. You have a question? Right? Now we are going to talk about autosomal dominant disorders. We have laid down, I hope, enough foundations, and we will also discuss autosomal, yes, recessive disorders. Now, in autosomal dominant disorders, let's suppose there is a man here and he marries or made this woman. Now, one thing you have to understand, that when this person is making sperms, right, what will happen to the different alleles? What will happen to homologous chromosome? He has two homologous chromosomes for this man, one from his mother and one from his father. Those chromosomes will be segregated into sperms. Is that right? For example, this person has two chromosomes. Let me tell you, chromosome. Let us suppose this is chromosome number 15, right? Two copies in this man. And this is chromosome number 15, two copies, homologous copies in this woman. But of course, they have complete set of chromosomes, but I'm just showing one set. Now, let us suppose that there is mutation here. There is a gene here which is mutant, right? And let's suppose this gene was making a protein which is called fibrillin. You know fibrillin protein? Fibrillin. Fibrillin is a protein on which elastin fibers are structurally arranged. So fibrillin peptide act as a scaffolding for elastin. So help in formation of elastic tissue. Now what I'm saying, on the chromosome number 15 at a specific locus, right? What is there? There is a mutation. Due to that reason, this woman is making less fibrillin peptide. Is that right? This is her genetic disorder here. Now here I want to tell you, if fibrillin is not enough, then elastic tissue in the body is not well, and this structural defect in these proteins clinically manifests itself as Marfan syndrome. Have you heard of Marfan syndrome? In Marfan syndrome, person is very tall, with long fingers, high arched palate, right? Marfan syndrome has three types of manifestations. There are skeletal abnormalities, there are cardiovascular abnormalities, and there are ocular abnormalities, right? So this woman has Marfan syndrome. For example, unfortunately, she has all three problems. She is very tall, right? Due to Marfan syndrome, this man was very keen to marry a tall woman because he is himself low height, so he thought his children should be very tall, but he was not knowing He is marrying a not tall woman, but tall woman with Marfan syndrome, right? So she is having very tall height due to abnormal joints and bones development. Is that right? Long fingers plus elastic connective tissue in aorta, and the cardiac valve is also abnormal. So she has cardiovascular abnormality. In the media of aorta, elastic fibers undergo degeneration, and there are chances that dissection of aorta may occur. Dissection of aorta is that normally blood should move in the lumen of aorta. Normally blood should move in the lumen of aorta, but in this female it's quite possible one day blood track into media and dissect within the media. Do you think normally blood should move in the media? No, because media was very weak due to elastic disruption. So she has a risk of dissection of aorta. Plus, if her mitral valve or aortic valve, elastic tissue is not well, these valves may regurgitate. At the top, her eyes from the distance are very beautiful. But unfortunately, the suspensory ligament or zonules which hold the lens in position, their elastic tissues disrupt. So lens cannot be held properly in their position. Maybe they're dislocated from their normal position. So she has dislocation of lens. She has abnormal cardiac valves, increased risk of aortic dissection. She is very tall, right? All these things are manifestations of Marfan syndrome. Why? Because at chromosome number 15, right, she has one mutation. Due to that, the fibrillin which is produced is not acting as normal scaffolding for her elastic tissue. So in her case, she is heterozygous, homozygous? Heterozygous. But because in the presence of normal allele, defective allele can produce abnormality. This person is suffering with that disease or not? She is suffering. Now let's suppose patient who is suffering, they should be shown like this. But in my diagram, I'm showing like this. This is the patient. When I say I'm going to draw this, it means there is abnormal phenotype. Here abnormal genotype is leading to abnormal phenotype. Unfortunately, this man was looking for a tall woman. He ended up with the Marfan syndrome, right? And now they married, right? Let's suppose what will happen. There are 2 daughters and 2 sons. What will happen there? Now listen. Of course, this man can produce, as far as chromosome number 15 is concerned, sperm with chromosome number, this chromosome, or every sperm will have either this chromosome or other homologous. Can sperm have both chromosomes? No. You know that, isn't it? In the same way, this female, when she will make ova, right? In the ovum, either she will put the healthy allele or she will put the mutant allele. Is that right? Now what we can say? All the sperm which are produced by her man, all the sperms are having, as far as this gene is concerned, all healthy alleles. But this woman, her chances to produce the ovum, every ovum, the 50% chances that ovum will have defective allele and 50% chances that she is making an ovum with the healthy allele. Is that right? This is which law? This is law of segregation. Law of segregation. During the gametogenesis, homologous chromosomes segregate independently. Is that right? Now, let's suppose we cross these. Now what happens? This chromosome crosses with this. So she has both what? Normal alleles. So do you think this child will be suffering? This is normal genotype, normal phenotype. Now, let's suppose this cross with that. What will happen? One normal, one abnormal. So this person will be genetically heterozygous, and this child, this female, she has a chance when she will grow up, she may manifest features of Marfan syndrome. Now we come to the boys. Yes, he is having both maternal and paternal copy healthy. So genotype normal, phenotype normal. And the other probability is this one. Here what will happen? Marfan. Now we can see one thing here, that here there are how many out of these four, two combinations are resulting into disease, right? So what we can say, what are the probability to produce disease in the offspring? 50%. Is that right? What is the probability? 50%. Is that clear? So what really happens that in autosomal dominant disorders, because usually they result due to the mating of one normal partner and one heterozygous, right? Due to this reason, heterozygous partner is producing half of the gamete with mutant product, half of the gamete normal. So offspring of this couple have 50% chances. Every offspring, every pregnancy has a chances, 50% chances to produce normal baby or 50% chances to produce abnormal. Am I clear? Now, let's suppose this person crosses with a normal female, right? Now what will happen? Yes, of course, chromosome 15 from normal female. Now this is normal female, and this was a female looking for a tall man, as it happens very commonly in female, but sometimes they end up with a very tall man. This is the Marfan. This is a female. Now when they mate, what kind of probabilities and combinations may result? Genotypic combination in the, now what is this? Normal with normal, right? Normal with other normal. Now mutant allele with normal combination, and mutant with other normal, abnormal, right? Now what we can say again, half of the female or half of the male in their progeny has a chance to have abnormal genotype and phenotype. Am I clear? Now I will put a question to you. If this couple produces one more child, this child is going to be normal or abnormal? Question goes to you. This couple has 4 children, right? 50% of the females are having Marfan genotype, and when they will grow up, they may manifest the disease. 50% of the boys. They have 2 daughters and 2 sons. She again becomes pregnant from the same person. What are the chances that, what will happen to this genotype of this baby? Yes. You want to think over. What about you? What do you think? Yes? 50-50. 50-50. Now here is the rule. Actually, whatever pregnancies occurred before, they have nothing to do with this pregnancy. You know why? Every time when gametes are made and one zygote is made, this is totally independent event, right? Regardless of how many affected or normal offsprings were before this pregnancy. Every pregnancy is an independent event, and we cannot say it will be definitely normal or definitely abnormal. Actually 50% chances to be normal, 50% chances to be abnormal. So what we can say in autosomal dominant disorders, right, for every pregnancy chances are 50% may be normal and 50% may be abnormal. This is first thing. Secondly, males and females in these families, affected males and females both can be affected. In autosomal diseases, males and females both can be affected. Is that right? Almost in equal number. Thirdly, another very important thing. Usually, if we are talking about a specific case, let's suppose this patient come to you in your office, right? This female is having Marfan syndrome. She is about 25-year-old. She is very tall and she has some other problems also. this should be considered proband. Proband is a person who is right now under consideration. Now, usually in autosomal dominant disorders, proband has an affected parent. I'm saying usually, exceptions are there, I will tell you later. Usually, in autosomal dominant disorders, proband has one history of affected parents, if you can get the history. Is that right? Now let's suppose, yes? Pardon?
And also a grandparent? It occurs in every generation?
Yeah, it is occurring in the generation after generation. Disease is manifested in this generation, then it has manifested in this generation, then it has manifested in this generation. Because even one copy is enough to manifest a disease. So generation after generation, our disease is manifesting in successive generations. So this pedigree is vertically running. This is vertically running because almost in every generation we have a person suffering with the condition. Now, let's look at this female, right? This female marries another person, right? We are sure that this person is absolutely normal as far as chromosome number 15 is concerned. About this female, suppose we don't know about we don't know her genotype exactly, but this female, when she grows up, she does not develop the manifestation of Marfan syndrome. Now listen carefully. What I'm saying, this is a female, we don't know about genotype, but she has one mother or one parent which are having Marfan. She is daughter of the Marfan, but herself she does not develop manifestations of Marfan. She marries a person which is sure normal, and she gets the children, and now in her children, one of them develop Marfan. Right? What is this phenomenon? Yes, this process is manifesting a very special thing, that disease is present here in this generation, right? In this generation, but this woman itself does not have the manifestations of disease, not having the abnormal phenotype, but one of her child has. Now, if considering this male normal, why this child is having the manifestation of disease? Because genotype here should be what? Abnormal. Now question is that this female was carrying an abnormal allele, but herself she did not suffer with the manifestations of disease. This type of situation occurs less commonly, because more commonly in autosomal dominant disorder, if one allele is defective, phenotype expresses, abnormal phenotype expresses. But occasionally, you may come across a person who is having abnormal one mutant copy, but still does not manifest what? Abnormal phenotype, right? Maybe there are some other genes which modify the influence of this, or some environmental factor, right? But her child, when grow up, have Marfans. We say here disease was present at the level of genetic material, but disease could not go up to the level of, it could not penetrate up to the level of observable physical manifestation. For this person, what we'll say, she was having the disease at genomic level. Is that right? But disease could not penetrate and express itself in observable characteristics. Is that right? So we say this patient, no, this person, because she cannot be said patient because she does not manifesting abnormal phenotype, but she does have abnormal genotype. Now here abnormal genotype is not leading to abnormal phenotype. This type of situation is said to be that this person is expressing reduced penetrance or non-penetrant person, where genotype is non-penetrant, it could not penetrate all the way to produce abnormal phenotype. Am I clear? Why it happens, we are not very clear, but some people believe it is due to interaction of some other modifier genes and some environmental factor. Is that right? Now in this case, if we follow this line, right, we say here this generation, this part has skipped the disease, right, and non-penetration is displayed here. Now another thing which I want to show, let's suppose we change the disease. I say this is not Marfan syndrome, it is some other set of chromosome, and this is, now I'm taking another example just to explain. Let us suppose this gene is making receptors for low density lipoproteins, LDL receptors. Now if this gene in some other family on some other chromosome, if this is expressing the receptor for LDL receptors, right, now what is happening, this mutant product is not properly acting as a receptor for LDL. Now what happened, LDL receptors are expressed on the hepatocytes, on the liver cells. LDL receptors are expressed from the liver cells, and from the blood, the circulating LDL, low density lipoproteins. Low density lipoprotein is very rich in cholesterol. So low density lipoprotein, which is circulating in the blood, is captured by these receptors normally on the hepatocyte, and low density lipoproteins are internalized in hepatocytes, right? So it means, let me make here liver. This is LDL receptor. It will catch the cholesterol or LDL and bring it inside the hepatocyte. Now, if there is normal level of cholesterol in blood or normal level of LDL in the blood, hepatocyte will be aware of that, because they are through these receptors taking the LDL in. Now, normally what happens, if your cholesterol level goes down too much, there will be less cholesterol going in. What will happen? Hepatocyte will produce more cholesterol to bring the level normal. Or if your blood cholesterol is going upward, then these receptors will take more LDL in, and hepatocyte will reduce internal production of cholesterol so that cholesterol level does not go too high. So it means these receptors are, LDL receptors are acting as a watching eyes for cholesterol level. And cholesterol level is going down. Due to these receptors, liver cells come to know that in the blood LDL is low and liver produce more cholesterol. Or if cholesterol is little high, due to these receptors, liver cell know cholesterol is high, they will internally produce less cholesterol. This concept is clear? Now, let us suppose this receptor is mutant, and due to some reason, due to its mutation, it can either this receptor is not present, or receptor is present but does not take the cholesterol in. What will happen to hepatocyte? Hepatocyte will become blind to the presence of circulatory cholesterol. Hepatocyte will become, they cannot see. They will become blind to the presence of circulatory cholesterol. Actually, when these receptors are defective, they are not taking the cholesterol in, hepatocyte will assume if no cholesterol coming in, probably cholesterol is very less in blood, and hepatocyte will produce a lot of cholesterol and flood the blood with cholesterol, and patient will develop what disease? Hypercholesterolemia. Person will develop which problem? Hypercholesterolemia. Is that right? Now, this familial hypercholesterolemia is a disease which results due to mutation, and if one receptor is defective, is that right? If one allele is defective, hypercholesterolemia can occur. Am I clear to you? Now, let us suppose this is not Marfan patient, this is hypercholesterolemic patient, marries a normal person. Now, 50% of the offspring, 50% of the females and 50% of the male have a risk of developing what? Hypercholesterolemia. Now, it is quite possible this is the female which has also having a genotype which can lead to hypercholesterolemia. But if she is taking a very low cholesterol from the diet and doing good exercise, what will happen? Her chances to manifest hypercholesterolemia will be low. You are understanding? Here what we see, that in spite of the abnormal genotype, environmental factor like exercise and less intake of like cholesterol is modifying the phenotype. Is that right? So phenotype depends on genotype as well as depends on environmental factors. Is that right? Now, in this case, this woman may not develop the manifestations of hypercholesterolemia, but her child develops. This is again an example where we say that due to environmental factors, disease is non-penetrant. Am I clear? So what I have explained the phenomenon here, that sometimes abnormal genotype is there in autosomal dominant disorder, but person does not develop abnormal phenotype. Such cases are said to express a phenomenon of reduced penetrance, right? Reduced penetrance means abnormal genotype is there, but it does not manifest to abnormal phenotype. Remember, reduced penetrance is a concept which is not usually applied to one patient. Now, what is the statement? Let me tell you. Usually, when we develop the concept of reduced penetrance, we study that disease, let's suppose Marfan syndrome or hypercholesterolemia in many families, right? And in many families, we find, let us suppose if there are 100 people with abnormal genotype, if there are 100 people with abnormal genotype of Marfan, but only 70 of them develop manifestation of Marfan. What is the penetrance? 70%. Again, usually penetrance is explained in terms of percentage, that how many people having abnormal genotype show the penetrance or non-penetrance. If I say that there are 100 persons with abnormal genotype for the Marfan, but out of those 100 genotypic abnormal persons, 70 people develop the Marfan manifestation, 30 do not. So what we'll say? That penetrance is 70%. And of course penetrance is less than 100%. So there is reduced penetrance. How much is reduced? 30%. Is that right? Any question up to this? Yes? You are saying if other person was also suffering? We'll talk about that, right? Just 1 minute. So what I was talking about, you are clear about this reduced penetrance concept. Then there is another concept. Let us suppose, go back to our example, and let us suppose this is pedigree about Marfan syndrome. Now how many Marfans we have here in this pedigree? 1, 2, 3. This was not Marfan but abnormal genotype. There is another Marfan here, another Marfan here, another Marfan here. Now I'm going to tell you another thing. Actually, we have seen there is one disease, one gene which is defective, right? But disease is appearing in 3 systems: ocular system, cardiovascular system, and skeletal system. Because all 3 systems have elastic fibers. So all of these systems, for their elastic tissue, depend on the presence of fibrillin. When fibrillin is not there, elastic tissue is disrupted in all these 3 tissues, and 3 systems suffer. Now, this phenomenon, when defect in one gene, can produce clinical manifestations in multiple systems, this phenomenon is given a special term. What is that term? One of you must be able to tell. Let me repeat. Many times it happens that one gene is defective, is that right? And due to one gene mutation, phenotype in multiple systems, physiological system, becomes abnormal. Here I was giving example of what? Marfan syndrome. In Marfan syndrome, gene on chromosome number 15 is defective, and clinically patient may manifest ocular manifestations, lens dislocation, may manifest cardiovascular abnormalities like regurgitation of the aortic valve and mitral valve, and dissection of aorta, and also may manifest the skeletal abnormalities like tall height, very long arms and fingers, right? High arched palate. So when defect in one gene can produce abnormal phenotype in multiple systems, we use a special term. What is the term for this condition? Question goes to these people, these four people. Any one of you can tell me. You, yes?
Is it locus heterogeneity?
What she's saying?
Heterogeneity?
No. Whatever you are saying, I'm not hearing, but I'm sure it is not right. Yes?
Does it start with a P?
I should repeat my...
No, does it start with a P?
I think I have to get my ears checked. Did you understand my question? It's very simple. One gene defected, but abnormalities are manifested in multiple different systems. The term is used pleiotropy. Have you heard of pleiotropy? She was saying something P.
Yeah, I couldn't say it, but I knew it started with a P.
Yeah, she knew that it started with the P, but I was very upset because so many things start with P, right? So, pleiotropy. So what is pleiotropy? Pleiotropism is the manifestation of, yes, abnormal phenotype in multiple systems in the body due to defect in one gene. Pleiotropism or pleiotropy. Is that right? So here we can say how we can check that there's pleiotropy or not in these cases. Listen, all these morphins we put together. It happens sometimes, now listen carefully, it happens sometimes this morphin has cardiovascular abnormalities and ocular abnormality, but no skeletal abnormalities. This person, now I'm going to another concept. First concept, look, one by one. First I discussed about the concept of reduced penetrance. Reduced penetrance is when you have abnormal genotype but you do not present at all, you present no manifestation of abnormal phenotype, right? All or none. But reduced penetrance is in whole big number of patients, that if you have 100 patients with abnormal genotype, if half of them show abnormal phenotype and half of them do not show abnormal phenotype, we say 50% penetrance. Is that right? After the concept of penetrance, then what I explained? The concept of pleiotropy. Pleiotropy is a concept where single gene defect may produce abnormalities in multiple systems. For example, in osteogenesis imperfecta. Osteogenesis imperfecta is a disease which results due to defective collagen peptide production. Many patients in osteogenesis imperfecta have abnormalities in bone structure and blue sclera. Right? Because sclera is very thin, collagen of the sclera is very thin and bluish venous blood shades through that. Don't tell anyone there is a blue paint over there. Sclera is very thin, collagen is so less in sclera that underlying choroid venous plexus, blue blood is reflected through that. Anyway, so, and in osteogenesis imperfecta, bones are so abnormal with very little stress, they undergo fractures. So in osteogenesis imperfecta, genetic lien is in collagen peptide gene, but clinical manifestations are in skeletal system and eyes. This is another example of what? Pleiotropy. If I say there's Marfan disease and some patients have, and some patient of Marfan, let's suppose this, are very unfortunate. They have all the manifestations. This unfortunate person has skeletal abnormalities, cardiovascular abnormalities and ocular abnormality. This person has, let us suppose, only ocular abnormalities. This person has cardiovascular and ocular abnormality. Right? Am I clear? Now this is another concept now. That different people with the autosomal disease may express the disease with different severity and with different manifestations. Now this is different, this concept is different than pleiotropy. Pleiotropy was that if one gene is defective, manifestation may occur in multiple systems. Is that right? Now I'm talking another concept. What is the other concept? That if you have 10 patients with Marfan syndrome all of those 10 patients who are Marfan syndrome, who are having that genetic lesion specific, but all of them do not have same severity, same age of onset, and same manifestation of Marfan. Again, for example, you have 10 patients with Marfan syndrome standing here. Just use your imagination, right? Now, some of them are having all problems, skeletal abnormalities and cardiovascular abnormalities and ocular abnormalities. Some of them have only ocular abnormalities and skeletal. Some of them have only, what is this? Cardiovascular and ocular. So, different Marfan syndrome patient may have different combination of clinical manifestation, number one. Secondly, some of them developed the disease when they were 15 to 20-year-old. Other may develop the disease when they were 35-year-old. It means the age of onset of disease is also different. So it means in the same disease, Marfan syndrome, different patient of the Marfan syndrome may develop different extent of the disease, that all the systems are defective or some systems are defective, or different onset of the disease, little earlier or later onset of the disease, or little different severity of disease. For example, you may have one Marfan syndrome where aortic valve regurgitate heavily, another Marfan syndrome where aortic valve regurgitate little. Now this is a new concept as compared to non-penetrance. Because when we are saying no penetrance, it means no abnormality, but genotype abnormal, but phenotype abnormality. When we say pleiotropy, it means one gene defect can produce or may produce multiple system defects. Is that right? But now I'm talking about another concept, that all the people who have one given autosomal dominant disease, different patient may have different severity of disease, different onset of the disease. Disease may express with different extent, disease may express at different age, disease may express with different severity. What is the term used for this thing? It is not anticipation. Anticipation is in trinucleotide repeat manifestation, when generation after generation disease process is occurring more severe and earlier. I'm not talking about that. I'm talking about that this person developed Marfan at the age of 20, and this person developed Marfan in the age of, let us suppose, 32. Is that right? She's having suppose Marfan with skeletal abnormalities and ocular. This is having skeletal and cardiovascular. Is that right? So what is this phenomenon? That both are though having same genetic lesion, similar mutation in the same locus. Is that right? But clinical manifestations of the disease or expression of the disease is slightly different in the extent of manifestations, severity of manifestation, and age of onset. The term here which is used, you already know. Today you are all trying to hide your knowledge. Variable expressivity. Disease is expressing in different patients in a variable way. What is the term here? Variable expressivity. Am I clear? I will just check, are you clear or not? There is a person who has a abnormal genotype, right, of the autosomal diseases. He has a abnormal genotype but no disease. What is this? No, reduced penetrance. Excellent. If there is one gene defected in autosomal dominant, that one gene defect may produce abnormalities in multiple systems. What is that? Pleiotropy. Different patient of the same disease may express the disease with different severity. Variable expressivity. So Marfan syndrome is a patient, in this pedigree, here we show non-penetrance. Another way to show non-penetrance is that, let's suppose this person marries a normal, she has these 4 children, all of them are phenotypically normal. Now this person marries this, and two of them are affected. Now disease is not present in this generation, but disease is present above and present below. What is this phenomenon? Reduced penetrance. Why? Because this person must be having defective allele, but he did not manifest the what thing? Abnormal phenotype. So reduced penetrance. Now we come to the next concept, and next concept is concept of the new mutation. Sometimes what happens that in a family a person develops Marfan syndrome, but there is no history of Marfan syndrome in upper generations. Let us suppose there is a boy who has Marfan syndrome, but his mother and father do not have any history of Marfan syndrome. Even their parents and their parents, if you can gather the history, there is no Marfan syndrome. What could be the probability? Probably new mutation has developed. Maybe in that family all the genetic setup on the chromosome of 15 was coming normal. But what happened? Let me start this pedigree here.